Good afternoon, and welcome to the webinar, COVID-19 Updates to Nursing Facility Surveys and Infection Control Deficiencies. I'm Michael Crow, a member of Husch Blackwell's healthcare group and leader of the firm's post-acute care initiative. Before we begin, I'd like to cover a few housekeeping items. At the bottom of your audience console, there are multiple application icons for your use during the program today. I'd like to take a minute to highlight a few of the key icons for you. First, if you're having any technical difficulty, please refer to the audience technical tips on your screen or click on the help icon at the bottom of the screen. It has a question mark and provides information regarding common technical issues. If you happen to be viewing the program from a mobile device, be sure to use Safari and turn your phone landscape for optimal viewing. When the screen is in landscape, you can click on the box in the lower right corner to change your layout. If you have any questions during the webcast, please submit your question via the question box. We will try to answer all questions during the webcast today, but if a fuller answer is needed or we run out of time, it will be answered later via email. We truly appreciate audience participation and encourage you to submit questions. A copy of the slides used during today's presentation, as well as other resources, are available in the resource list. The icon looks like a folder at the bottom of your screen. This program has been approved for Illinois, Iowa, Missouri, Nebraska, and Tennessee continuing legal education credit. Wisconsin and Texas approval are pending. To report hours in Illinois, Nebraska, Tennessee, and Texas, click on the CEU icon at the bottom of your screen and complete the questions. All other states are self-reports. You may download the certificate of attendance from the certificate icon at the completion of today's program, and a copy will also be mailed to you tomorrow. A recording of the webcast will be available tomorrow for watching and sharing. Once available, a link to the recording will be emailed to you. That's it for housekeeping items, so let's get started with our program. Joining me today are Ragini Acharya and Liz LaFaux. Ragini helps healthcare clients navigate complex compliance and transactional matters in order to optimally position them for day-to-day and long-term growth. Focusing her practice on regulatory issues, Ragini advises on cost-effective, proactive compliance and advocates for clients before state and federal agencies when they face claims that threaten to interrupt patient care. Liz is a lawyer and registered nurse. Her legal training and clinical background give her a unique advantage in counseling healthcare providers with everyday legal challenges such as regulatory compliance, professional licensing, and government investigation. Liz represents clients before professional boards and governmental agencies, contests deficiencies on behalf of long-term care facilities through informal dispute resolution and the federal administrative appeal process, and assists with defense and maintenance of professional licensing. She also provides medical malpractice defense and assists healthcare organizations in responding to government investigations, audits, subpoenas, and complex document production requests. So what are we going to cover today? First, we're going to start with a quick background of where we've been and why we're presenting this webinar. We'll move on to a review of critical program memoranda that have been released by CMS's Quality, Safety, and Oversight Group, and then provide an update regarding enforcement and penalties. Liz and Ragini will do a deeper dive in infection control deficiencies and associated tags, and we'll conclude with a discussion regarding contesting deficiencies in enforcement. I submit to the audience that the first major news story that caught the nation's attention and certainly caught my attention concerning COVID-19 was about a nursing home. In March, it was reported that some of the residents of Life Care Center nursing home in Kirkland, Washington, had been killed by COVID-19. Soon after that, almost every news outlet in the country went out to find a story involving COVID-19 and the residents of their local nursing homes. In March through May, COVID-19 hit very hard up in the Northeast, particularly in New Jersey, New York, Connecticut, and Pennsylvania. And all of the attendant stories about nursing homes came out from that outbreak. In May, it looked like things were looking up. The United States reopened, but made the promise of focusing on the most vulnerable citizens, the aged and the disabled. In June, CMS announced that it was going to tie funding to states under the CARES Act for increased survey activities, and that that funding would be held up using performance-based metrics. And now, presently, we're having a spike in COVID in new areas of the country. Fair or unfair, there's a story in the national conscience that nursing homes are a big part of the COVID-19 problem. And now more than ever, CMS has the nursing facility industry under a microscope. Our concern is that this increased focus is going to result in a wave of enforcement actions. We're hoping this webinar will help you prepare for that eventuality.
Hi, so my name is Liz, as Michael said, and our next couple of slides focus on some CMS public actions that have come down. This is a pretty convenient timeline that CMS produced last week, and we actually borrowed. And I'm not going to read through everything, but kind of the big announcements that were made by CMS happened in March, and that concerned the use of personal protective equipment, restriction of visitors, it related to screening of entrants into nursing homes, and then the prioritization of survey activities, which we'll talk about a little bit more in some later slides. And then moving on to the next slide, it kind of goes through actions that occurred all the way up through June 8th, and we've gotten some guidance on the nursing home data and results from targeted inspections conducted by the agency since March 4th, and that is now uploaded to Nursing Home Compare. In June 8th, CMS started issuing citations for F884 violations, which we're going to talk about a little bit more in some later slides. Overall, we thought that this timeline on these two slides was helpful because once you have the copies of the slides, it provides links to a lot of this guidance in memorandum. And one thing that we've been seeing, which we'll discuss more in some of our survey enforcement slides, is that it is helpful to have a timeline of the guidance that has come out from CMS and the CDC because that can, affect what the facility was doing and whether or not it was in compliance. We've seen where sometimes CMS will try to cite a facility for violations, for example, regarding the use of PPE, dating back to March, when the alleged violations don't necessarily match the guidance that was out at the time. So we thought these two slides were helpful because it links some of this different guidance. One thing we've been seeing some some of our really successful facilities do in managing COVID is keep a binder with all of the guidance that's come out, kind of tabbed by the date it came out. And then if you're in a survey situation, you have an easy reference where you can go back and see, were we really out of compliance in March, or were we following the current guidance regarding PPE use? So that covers those two slides, and now I will turn it over to, I believe, Ragini.
Thanks, Liz. Yes, my name is Ragini Acharya. I'm just going to talk a little bit about QSO 2012 and QSO 2020. So to start, QSO 2012 was issued on March 12th, and CMS addressed the suspension of survey activities in this QSO. It used its authority under Section 1135 to suspend certain federal and state survey agency surveys and delay revisit surveys, and at the same time reprioritizing other types of surveys. So the surveys that it chose to prioritize in descending order were immediate jeopardy complaints and allegations of abuse and neglect, complaints alleging infection control concerns, including those facilities that had potential COVID-19 or other respiratory illnesses, revisits necessary to resolve current enforcement actions, initial certifications, and then, as is on the slide, those facilities with histories of infection control deficiencies at the immediate jeopardy level in the last 3 years, and those facilities that had just general history of infection control deficiencies lower than the immediate jeopardy level. This particular QSO included 2 attachments, the first of which was Attachment A, which was a survey planning in facilities with active or suspected COVID-19 cases. And it provided a protocol for surveyors in coordinating investigations and how to prioritize immediate jeopardy threats, and how to decide when CMS will authorize on-site surveys, investigations in facilities with those suspected cases. And then with respect to Attachment B, we'll discuss this more in the next slide, which is the infection prevention and controlling immunizations attachment. So this is the tool used to investigate compliance with respect to 3 of the F tags, F80, 8081, and 883. This particular tool addresses, standards for, the general slew of like hand hygiene, PPE standards, laundry services, and with respect to the version that was published on March 4th, these were limited to 880, 881, and 883. But as we'll discuss later, the revised version, which was issued, I believe QSO 2029, includes more for the COVID-specific F tags, which Liz will address in a couple slides. And then with respect to QSO 2020, which was issued on March 20th, again, CMS reiterated prioritization of certain survey activities, and it modified the timetables and deadlines for the performance of these certain required activities, again, delaying revisit surveys. And with respect to the timing, initially this prioritization period was set only to be 3 weeks. However, according to a nursing home call on April 15th, CMS has communicated that it's been extended until it communicates otherwise. At this time, we don't believe it's communicated otherwise, that this prioritization period is still in effect. And Michael will talk a little bit more later about the current political environment and how that may affect the prioritization being affected. But again, the types of surveys being prioritized, those related to complaints and facility reported incidents, and then targeted infection control surveys. Certain surveys obviously are suspended and not authorized, including standard surveys for long-term care facilities, and again, as I said before, revisits. And the infection control checklist included in this QSO can be used for self-assessments by facilities to kind of allow for a voluntary review of their infection control plan and protections. Then next slide, I believe. Liz, you're going to talk about self-assessments.
Yes, I am. So this kind of relates to the increased survey activity that we're seeing around COVID-19. And of course, as Michael said in the beginning of this presentation, nursing homes house our citizens that are most vulnerable to COVID-19. So even aside from concerns about enforcement, it is a real opportunity for nursing homes to really do everything in their power to protect these vulnerable residents. And I know that this has been really difficult for all of our facilities, but most facilities are doing a really exemplary job. So this slide just is some things that facilities should be focusing on. First of all, the CMS and the CDC have tools that include self-assessments and survey readiness programs that facilities should be using to prepare for a potential COVID-19 outbreak, which, even if you're perfectly complying and you have a great infection control program, you may still see COVID-19 in your facility. So we've got links to the CMS Focus Survey for nursing homes. There is an updated version that will be linked on the next slide. That's the one that I would encourage using currently. And then there's also the CDC's Infection Prevention and Control Assessment Tool. Some areas to prioritize, and these are also areas where we're seeing folks have some survey enforcement issues, are standard precautions. So that's hand hygiene, PPE, transmission-based precautions. What's setting in now, since this has been going on since February or March, is that we're seeing healthcare staff have what's called caution fatigue. And it really is, it's exhausting to constantly try to be in a state of readiness and using all of these protective measures. And so even at really great facilities, we're seeing healthcare staff start to slip on some of these precautions. For example, folks are pulling their mask down to their chin. Obviously, it's not doing any good down there, but folks are, they're just having some of this caution fatigue set in. So it's really important that facilities have their leadership actually monitoring PPE use now more than ever. Resident care, including resident placement. It's very important that facilities have a plan for if you do have your first COVID positive resident. The kind of general recommendations is to do resident cohorting, and facilities that are doing that are having more success and less survey issues than those that are mixing their COVID positive with their COVID negative residents. There's guidance coming out constantly on this cohorting, and I just saw something, I think yesterday, from CMS and CDC saying that you don't necessarily need to have your patients that are going out to dialysis in the COVID unit. That increases their exposure, and it was recommending that they instead stay on their regular unit and just wear a mask for source control when they go out to dialysis. Obviously, if they have symptoms of COVID or they test positive, then that's a different situation. But I know some facilities were just having all of their patients that had routine outpatient appointments kind of treated as potentially exposed, and that's not following the most recent guidance, which, like I said, I just saw yesterday. This kind of goes back to my my earlier slides that I did, which just shows how important it is that we try our best to stay on top of all this guidance that's coming out. Infection prevention and control standards, policies, and procedures. We're going to talk about this a little bit more, but the government is doing audits to see whether folks have their infection prevention and control standards, policies, and procedures in place, and if those are sufficient to manage a COVID-19 situation. Similarly, emergency preparedness policies and procedures, those are required by regulation, and the government is taking a closer look to determine if those are actually in place. Visitor entry, education monitoring and screening of staff, infection surveillance. There's a lot of overlap in these areas. Unfortunately, we're seeing a lot of facilities get into trouble with this screening. and the infection surveillance and the visitor entrance. First of all, a common mistake that's occurring is when the surveyors show up to do one of their focused infection control surveys that we're going to talk about more, they are not being screened. So anybody that comes into the building has got to be screened. Temperature taken, ask the questions. We want to know, do they have signs or symptoms of COVID-19? Have they had any recent travel? Have they been exposed to a COVID-19 positive person? Have they tested positive for COVID-19? So those are the questions everybody should be asked. Everyone should have their temperature taken. This goes for staff and visitors. And that needs to be documented because, as we all know, the saying in healthcare is if it wasn't documented, it wasn't done. We as lawyers can try to help a facility work around that issue, but really the best thing to do is just to have your documentation of your screening in place. We've seen issues where folks are only writing down temperatures for each day and not making it clear that they also screened all the required questions. We've seen issues with folks that report having symptoms of COVID-19 still being allowed to come into the facility or work. So again, it's not enough to do the screening. You have to actually follow through on what the screening shows. So if someone has a cough, unfortunately, unless they've been tested for COVID, we have no way of knowing if that cough is related to COVID-19 or if it's from allergies, and so those folks should not be allowed in the facility. That's kind of the hard line that we've seen CMS take, and so that's what we recommend facilities do as well.
Hey, so Liz, this is Mike.
Sure.
I'm sorry. Can we go back to the last slide for a second?
Sure.
Yeah, I was just going to point out. And we should probably address this more at the beginning, but in addition to these standards, and these are the CMS and CDC standards, we just want to make and reiterate, make the point that state licensing standards will a lot of times build on some of these areas, and so it's important for providers to look not only at these CMS standards, but to also look and see if their state licensing agencies are putting out extra guidance, so to speak, around these issues. In my home state here in Texas, for instance, this slide here says providers are encouraged to use the CMS tools. They're not encouraged. It's basically being used as the Bible. And if you're not in compliance, even with things that where the wording might say it is recommended that, in Texas, our Health and Human Service Commission has been very aggressive on interpreting those recommendations very literally and applying them very literally. And the same with every one of these prioritization items. Texas has its own booklet now on standard precautions, resident care, surveys and surveillance and entry and all that. So again, check with your states, because your states are probably issuing their own guidance that may meet or in a lot of cases exceed what CMS and CDC are putting out. Liz, sorry.
All right. No, thanks, Mike. That was helpful. So thank you for adding that. I absolutely agree. We don't have quite as much in writing in Missouri, but I would say that we're seeing something similar with enforcement, which is it's really not just a suggestion to use these tools. It's being treated as mandatory by CMS and by our state survey agency. So on the next slide, we're talking about QSO 2029, which introduced some new F-tags, just what we needed. F884, which has to do with COVID-19 reporting to the CDC, and F885, which is COVID-19 reporting to residents or representatives and their families. And then we've got a link to the CDC reporting site. So this slide I'd like to use to talk a little bit more about if you have a COVID positive case. So obviously that needs to be reported, and we now have this tag F884, which relates to the requirements to report to the NHSN CDC module, and that's supposed to be done at least weekly. So that's a new requirement, and failure to report can result in enforcement actions, which we'll talk about later. F885 is the new tag that concerns the reporting requirement. You've got to notify residents, representatives, and family if you do have a positive case in your facility. As a general recommendation, what we've been encouraging our clients at our facilities to do is if they have a COVID positive, they should be working hand in hand with the local public health authority. So calling that health department, doing what's recommended by the health department. The health department can assist in widespread testing, which is recommended, once you have one positive case. So working very closely with the health department is the number one recommendation that we're probably making to our facility clients right now. A lot of folks are also releasing a press statement in conjunction with the health department. That's not a bad idea. It shows that you're that you're handling the situation and being proactive. We're also seeing a lot of other infection control tags cited. Mainly it's just F880, which we have a slide on that coming up here soon. And then there's some updated resources on CMS's NH website, and those are linked below. Again, as Mike was saying, see what your state is recommending, but generally this is not so much a suggestion anymore as a requirement. And then this bottom link on the slide has the QSO 2029, which at the bottom of that memo, it's got the updated COVID-19 focus survey for nursing homes. That includes survey screening for the new tags F884 and F885. If you haven't already done kind of a mock survey with your facility, I would highly recommend that you use the screening tool that's linked below to do this. As we're going to discuss, these infection control focus surveys are coming, and they're coming quickly. So if you are not already in sort of a constant state of survey readiness with a special focus on infection control, now's the time to do that. And now I get to turn it back over to Mike.
Thank you, Liz. Oh, thank you. So I'm going to talk a bit about QSO 2031 that came out on June 1. This addressed three major issues. One are the new COVID reporting requirements for nursing homes. In conjunction with the CDC, CMS has set up a program for facilities to report their COVID cases and to help them identify problem areas in a quicker amount of time. This is definitely up and running. Between March 4th and May 31, CMS had already reported having done 8,300 surveys and had posted 5,700 of those survey results on a dedicated data site on the CMS website. And as of June 14th, they had reported a total of, and I'm reading this right now, 111,508 confirmed cases of COVID in nursing homes, 76,547 suspected cases, and 30,794 deaths. So obviously, CMS is taking its responsibility for not only collecting this data but also reporting it to the public pretty seriously. The second thing that was outlined in this QSO is something I addressed at the beginning of the seminar, which was this initiation of performance-based funding that's related to the CARES Act. The CARES Act actually had an additional $80 million made available to CMS to give to the states to help with their survey activities. Instead of simply releasing that funding, though, to the states, CMS has put criteria that the states have to abide by in order to get that money. So CMS has instructed, among other things, that the states have to have 100% of their focus infection surveys completed by July 1. In fact, this, more than anything, was probably the impetus for our decision to go ahead and do this seminar, because that means you, as nursing facility owners and operators, can expect at some point to be getting a survey sooner rather than later. States have to request the supplemental funding. They've got to show their compliance with this. And if they don't meet their deadlines, CMS can actually put them on a corrective action plan and ultimately even give that money away to states that are performing. So there's, I think these kinds of incentives are going to force the hands of state survey agencies to get out there and survey. Finally, this QSO reported enhanced penalties for noncompliance, and we've got a slide on that a little bit later, and we'll be talking about some new penalties associated with these F tags. A copy, finally here on the slide, you can see a copy of the QSO can be downloaded from the attached website. If that goes. I want to talk a little bit about quality improvement organizations. These QIOs are supposed to be helping nursing homes identify greatest areas of infection control problems, and then help them create an action plan and implement steps to establish the strong infection control and surveillance programs. They can train your staff on proper use of PPE, cohorting residents appropriately, and transferring residents safely. They can also help you with monitoring compliance with infection control standards and practices in nursing homes. These QIOs have been around for a while. I believe they were initiated in November of 2019, but have been dedicated now mainly to helping with the COVID crisis. CMS is also offering weekly seminars that provide some useful information around the standards that CMS is putting out, and is an additional resource associated with this quality improvement effort. We'd like to also add that various states have maybe not set them up as, quote, QIOs, but definitely have made them available as a resource to nursing homes in addition to the national QIOs. And a good example of this is in the University of Missouri. Their School of Nursing has set up something called, I'm going to probably screw this up, QITMO, or KITMO, but it's a quality improvement plan or quality improvement program that is sponsored by the University of Missouri. And I haven't had my clients access it, but Liz has for her Missouri clients, and is apparently a really good program. So there are some organizations out there that can help you meet all these different criteria. And I think with that, where is my Excuse me.
Thanks, Mike. That's
yeah. I
again.
was going to say.
So this is Liz. I've kind of touched on what's happening, as has Mike and Ragini. You know, we're seeing these increased infection control surveys. If your facility hasn't had one yet, you can expect one soon. Facilities that have not undergone an infection control survey can expect one before July 31st, 2020. The types of enforcement that we're seeing range from, well, it's the usual enforcement, first of all. So as a recap, whenever you get a deficiency that's D level or higher, you can see a range of enforcement actions. So there's civil money penalties, which are imposed by CMS. Then there's, if you have a serious deficiency, such as an immediate jeopardy, and it's for an infection control issue related to COVID, you can expect to see a 23-day notice of termination of your Medicare certification or imposition of temporary management. For pretty much any deficiency, D or above, you're going to probably see DP&A that may not go into effect depending on the time that your facility is able to get back into compliance. But that DP&A is that denial of payment for your new Medicare Medicaid admissions. And then generally all these surveys, you're going to have the penalty of the nurse aid training prohibition if you get a D or higher. What we've been seeing is folks, I'm going to go back here to this slide, folks that have a COVID-19 positive case and that are not perfectly compliant with recommended infection control practices are generally getting immediate jeopardy level deficiencies. Depending on the facility's history and whether or not the issue is widespread, you can be looking at a substantial civil money penalty in addition to all the other penalties that I discussed. We've seen them as high as $500,000, $600,000, and I know they can go as high as $1 million. So you can be looking at a huge fine. So really, it's important for everybody to be in this constant state of survey readiness, pay attention to those prioritization areas that we discussed before. But if you have a COVID-19 positive case, you should be on high alert. So that is the time to dedicate as many resources as possible to the facility. As we'll see on the next slide, the survey prioritization of these focused infection controls are kind of circling around outbreaks. So by June 30th, which has already passed, you were supposed to have a survey done if you had a previous COVID-19 outbreak, and that's defined as cumulative confirmed cases, bed capacity 10% or greater, or 10 or more deaths reported due to COVID-19. And then going forward, there are supposed to be on-site surveys within 3 to 5 days of identification of any nursing home with 3 or more new COVID-19 suspected and confirmed cases since the last report, or 1 confirmed resident case in a facility that was previously COVID-free. So I think the biggest recommendation that we can give is that do your best to be ready for these surveys even before you have COVID positive. But if you have COVID in your facility, that is the time to pull whatever strings you can to put as many resources as possible into that facility so that when the surveyors show up, it's clear that you are fully compliant with the CMS, CDC, and the local health authorities' recommendations. And then I'm turning things back over to Mike.
Thank you, Liz. I'd add and people probably know this already, but we talk about these tags and we talk about what CMS is coming in or the state is coming in to survey for, and they are focusing on infection control. But always remember that once they're in your facility, it's the old adage, if they see a problem, they're going to write it. For this seminar, I was flipping through some of those 5,700 statements of deficiency that they've been nice enough to post online. The random ones I looked at, and it wasn't a lot, but not one of them actually had been tagged with F880 or any of those 800 F tags. They were getting tagged for just the normal stuff that facilities get tagged with all the time. So, failures to report suspected abuse and neglect, or other medication errors. I mean, it's just the random stuff. So you need to be ready to talk about infection control. You need to be ready to prove to them that you're in compliance with all the new requirements that they're putting out there. But if you've got any lingering problems in your facility, if you had a survey right before this outbreak occurred and they had identified a few things, even if they cleared those deficiencies, surveyors have a tendency to go back, reread the last survey they did, and just double check and see if you're still in compliance with whatever it was that you were tagged with. So just keep all that in mind. As I mentioned, QSO 2031 had some specific penalties associated with infection control. I'm going to go over them real quick. And they're here on the screen, so you can read them at your leisure. But noncompliance with infection control deficiency when none have been cited in the last year or your last standard survey. You can see that if it's a D and E, they'll ask for a directed plan of correction. But if it's more widespread at level F, they can add denial of payment of new admissions, and in addition to the directed plan of correction. If you've had noncompliance for infection control cited once in the last year or since your last standard survey, and by the way, of course, infection control is always a favorite tag for CMS to write. If that current noncompliance is not widespread at a D or E level, in addition to what we were just discussing, you can face a per instance CMP of up to $5,000. And if it's at level F, that's increased to a per instance CMP of $10,000. If you've had noncompliance that's been cited for infection control deficiencies twice or more in the last 2 years, then the stakes get higher. D and E, it can be a $15,000 per instance CMP or a per day CMP of $15,000. And then at level F, that goes up to $20,000. If the home is cited for current noncompliance and it's a control level deficiency at the harm level, GH or I, they're going to do a directed plan of correction, the discretionary denial of payment for new admissions, and CMP can then look at imposing whatever is in its arsenal of enforcement tools in the CMP range for that at the level of non-immediate jeopardy. And finally, immediate jeopardy, you can expect all the above, and on top of that, whatever CMS can usually impose at the IJ level. And on top, so we talk a lot about what CMS has been doing and the pressure CMS has been putting on nursing homes and on the states. It should be noted that CMS itself is under scrutiny, so this should not be surprising. We live in a weird political world right now, and so on June 16th, the House Select Committee on Coronavirus launched a wide-ranging probe into the president's oversight of nursing homes during the spread of coronavirus. They've sought information from CMS itself, and they have sent letters to 5 of the largest nonprofit nursing home companies in the country seeking information on their response to coronavirus. Some of the things that this letter addressed, the members were questioning why CMS had altered its survey protocols at the beginning of the crisis. You know, why were they simply putting certain things on hold and not following up on anything but IJ tags? So some of that has come under scrutiny. We've also started to see letters being issued by the Office of Inspector General to some nursing home clients, again, requesting information regarding how they are complying with these PPE and infection control protocols. And for some reason, they started coming out right after this probe was initiated by the subcommittee. So again, these things tend to escalate very quickly, and and it's just additional pressure that's going to be put ultimately on the nursing homes to demonstrate their compliance with these protocols. And with that, I'll turn it over to Liz and Ragini.
Thanks, Michael. So yes, we're going to talk a little bit about the F tags, infection control F tags, and then the more recently issued COVID-19 F tags. It's important to develop a thorough understanding of these F tags and emergency preparedness requirements to avoid the deficiencies and any steep fines that are associated with it. So the biggest one is F880, which is the infection prevention and control F tag, which this one specifically requires that nursing facilities establish and maintain an infection prevention and control program that's designed to provide a safe, sanitary, and comfortable environment and to help prevent the development and transmission of communicable diseases and infections. This plan and program must be reviewed and updated annually and as needed. And it requires, a system for the prevention, identification, reporting, investigation, all these the slew of requirements to prevent communicable diseases. And not only is it just for patients, this system needs to be put in place for all residents, all staff, visitors, volunteers. So this type of a program and plan needs to encompass not just one type of individual. It needs to really be thinking about it in a holistic sense. It requires written standards and policies, and these are frequently cited about infection surveillance, reporting potential incidents, standard and transmission-based precautions, isolation procedures, and employee contact, direct contact with residents or their food, hand hygiene. It also requires, having a system for recording incidents identified under the program and the corrective actions that are taken by the facility. And also, very importantly, it requires the facility to have policies and procedures in place addressing the transport and handling and processing of linens and how to separate contaminated and clean linens and proper linen storage. Again, this attack has a lot to it. Standard precautions, making sure that COVID positive residents are separated from those tested negative, having designated staff in the units, the COVID-19 units, and not intermingling those staff with the ones that are not in the units, ensuring that proper screening tools are in place, ensuring that the clinical leaders are properly using PPE, and then obviously everyone wearing a mask. This is hugely important. Often, as Liz mentioned before, something that might be with fatigue that is occurring with this going on for months now, tending to be a little bit lax about this type of face coverings or masks on a daily basis. And again, the FTAG also goes over the precautions, standard precautions, transmission-based precautions to do with hand hygiene, use of PPE, properly cleaning and disinfecting of items, as well as contact precautions using appropriate PPE when entering a room and exiting a room, droplet precautions, wearing the face mask appropriately, keeping residents in private rooms, and then finally airborne precautions for aerosol generating procedures. With respect to F881, 882, and 883, these are, we'll go over these very briefly. These just deal with antibiotic stewardship program and requires that the facility have ensure the proper use of antibiotics. Again, COVID-19 not really applicable to that, just given that it's a virus, not a bacterial infection. Still important to keep it in mind as surveys are taking place on a general level. F882, ensuring that there's an infection preventionist person in place. And this person must be specifically qualified in their education and training and experience in infection control. Actually, CDC has a handy training course, which we've linked here, and it's available on the CDC website. And then finally, with respect to F883, influenza and pneumococcal vaccinations meant to reduce the risk of residents acquiring or transmitting these types of diseases, and providing education to the residents on the benefits of treatment and potential side effects of the vaccinations, and also requiring documentation in the medical record regarding these education and treatments. Then we'll move on to 884 and 885 on the following slide, which, as Liz mentioned, in QSO 2029, these were the new regulatory tags implemented by CMS, and these follow the rest of the infection control group at 880 through 883. And they put into place these two new reporting requirements with respect to 884, dealing with reporting to the CDC, which will be conducted off-site by CMS federal surveyors, so state surveyors will not be citing to this FTAG. It's a requirement to report confirmed or suspected COVID-19 cases to the CDC to assist with infection surveillance. CDC or CMS reports that there are some common issues that they've been seeing. This includes, the facility not reporting the right CCN, not selecting the right facility type, missing the deadline for reporting, or reporting the wrong week of data when they submit the report. So in order to, prevent these types of technical issues that can result in some fines, you should make sure your CCN number is correct. Double check your facility type is correct and that the data is being submitted on time and for the correct week. And importantly, entering 0 if the answer is 0 for questions. So blank data will be considered missing data. So remember to complete all pathways. And then finally, with respect to reporting to residents, this is another reporting requirement issued and implemented through QSO 2029. This requires that the facilities communicate with their residents and the residents' representatives and family members regarding the existence of COVID-19 in their buildings. Reasonable efforts need to be made to relay this information, and while that doesn't necessarily mean individual phone calls, that would probably be best practice. Surveyors are going to look to identify those mechanisms that the facility is using to inform their residents and representatives about the COVID-19 data. So, and if the nursing home is found not to be in compliance with this particular reg, the facility will receive a citation, and enforcement actions will be taken that follow the QSO guidance issued in 2020. Liz, do you have anything to add to either of these, any of these slides?
No, not really. I would just point out we've got on this slide, consider having a dedicated communication liaison. Folks that are doing that are having a much easier time with staying on top of these communication requirements.
Okay, great. I think with that, I'm going to turn it over to you, Liz, to talk about 2567.
Sure. So I'm going to run through these very quickly because we're almost at the end of our hour. But for F884, we have some information and tips on these next two slides. The main point that I wanted to make is that if your facility is making a good faith effort to get this reported and encounters issues or made a mistake, CMS and CDC announced on the last nursing home group call that I was on with CMS on June 10th, they are willing to work with facilities that are, having a good faith effort to get this reported and are encountering technical difficulties or maybe made a small mistake. The official recommendation when that occurs is to pursue IIDR, and then we have a list of things that you should compile for that. And of course, legal counsel would be happy to assist with an IIDR if you feel like you need that. It may also be appropriate to do an informal phone call to the CDC kind of technical support and explain the issue. Probably based on the latest guidance, they're still going to require you to go through the IIDR process to avoid an enforcement action, but it might be worth trying to get it informally resolved before you reach the enforcement level. That's all I had for those two, and I'm going to turn it over to Mike to talk about survey appeal rights.
Okay. I'm going to flip back to contesting. Oh, let's see. Yeah, the notifications. By the way, again, we come back to this kind of recurrent theme. States will also, some states have their own reporting requirements in addition to these for CMS and the CASPER system. So again, for instance, in my home state, Texas, the Texas Health and Human Service Commission has a program where you're supposed to do similar types of reporting, and even certain area counties within the state have their own reporting requirements. So again, it's important to keep abreast of not only what CMS requires, but what the state requires, and even checking in on what the county may require. I'm going to talk very briefly about survey appeal rights. Of course, the regulations in federal law provide for appeal rights when a sanction of some kind is imposed. You technically don't have the right to contest a deficiency. What you have the right to contest is a penalty, a sanction of some kind. An informal part of this, informal dispute resolution and independent informal dispute resolution. Depending on the state you're in, this can be advantageous or, frankly, in some states, a waste of time. The state of Missouri has historically had a very good IDR program where the IDR reviewers actually review the information that's being submitted and will, on occasion, actually side with the nursing home and make recommendations regarding the associated deficiencies. Other states, not so much, and I'll leave that to another time to talk about. The other major avenue for appeal is to the Federal Department Appeals Board, which is housed within the U.S. Department of Health and Human Services, separate from CMS. But at that level, the ALJ, there's a two-level appeal process, and again, unfortunately, your chances of success within the DAB are limited. Fortunately, there is a appeal to federal court if you feel so inclined. I'm going to have to end it with that. I'm going to talk to you today with a few reminders. This program has been approved for Illinois, Iowa, Missouri, Nebraska, and Tennessee continuing legal education credit. Wisconsin and Texas credit is pending. To report hours in Illinois, Nebraska, Tennessee, and Texas, click on the CEU icon at the bottom of your screen and complete the questions. All other states are self-report. You may now download the certificate of attendance from the certificate icon at the bottom of your screen, and a copy of the certificate will also be emailed to you tomorrow, along with a link to the recording. Before you leave the program today, be sure to complete our short survey by clicking on the icon at the bottom of the screen. Your feedback is reviewed and will help us in providing future quality programs. This concludes our webinar. Thank you very much.